Hello. So it's been so long that I haven't posted a video, and in previous video we were discussing this schwannoma. So let us see it one more time. Classically, at the cerebellopontine angle, benign. Its location is cerebellopontine angle. It is benign, and let me change the marker. Yes, it is benign and it involves cranial nerve 5, 6 and 7. 5, 7 and 8. Sorry. 5, 7 and 8 but can be along any peripheral nerve. So there is no restriction to the number of nerve. It is often localized to cranial nerve 8 internal acoustic meatus, which is called vestibular schwannoma, and can present as hearing loss and tinnitus, as it is related to the cranial nerve 8, and especially its vestibular branch. So the symptoms we will get will belong to our hearing. So hearing loss and tinnitus. Bilateral vestibular schwannomas found in neurofibromatosis type 2. Its treatment is resection or stereotactic radiosurgery. Schwann cell origin. Yes, its origin is Schwann cell, and its tumor marker is S100. It is biphasic, dense hypercellular area containing spindle cells, alternating with hypercellularity and myxoid areas. So these are some pictures regarding these brain tumors. So from today we will start from here. Childhood primary brain tumors. Number one is pielocystic astrocytoma. It is a low-grade astrocytoma. Low-grade means you can see it is most likely benign, and most often primary brain tumor in childhood. Usually well circumscribed. Yes, well circumscribed is also a feature of something which is benign. In children, most often found in posterior fossa. Location is posterior fossa. And in posterior fossa, we already know that we have cerebellum, and in cerebellum, we have astrocytes. So maybe supratentorial, and it is benign, as we have discussed previously, and has very good prognosis. So its origin is astrocyte. GFAP is its biomarker. It is bipolar neoplastic cell with hair-like projections, like Purkinje cells, which are also in cerebellum, associated with microcytic and rosenthal fibers. Yes, rosenthal fiber is something unique. These are eosinophilic corkscrew fibers, cystic and solid corkscrew. In picture B also shown in picture B corkscrew. So this is corkscrew, and let's go back. Yes, it is cystic and maybe solid and gross. Next is medullo. So let's see it one more time. It is some circumscribed, means it is benign in posterior fossa, mostly involving the cerebellum, and it is a good prognosis. It is most common. Oh, sorry. It is most common primary brain tumor. Yes, most common primary brain tumor in childhood. It has astrocytes in origin. GFAP is its biomarker. It is bipolar, have hair-like projections and rosenthal fibers. which are corkscrew type fibers. It may be solid plus cystic. So the next is medulloblastoma, most common malignant brain tumor. It is malignant. It is commonly involves cerebellum, can compress fourth ventricle, causing non-communicating hydrocephalus or obstructive hydrocephalus. So its symptom would be headache, papilledema, can involve the cerebellar vermis, which would result in truncal ataxia, can send drop metastasis to spinal cord. Form of primitive neuroectodermal tumor. It is a neuroectodermal tumor. PNET would be its tumor marker. Homer right rosette, small blue cell surrounding central areas of neuropil. Synaptophysin. Yes, synaptophysin is its tumor marker. Synaptophysin is its tumor marker, and this is some form of thing which may be involved in the primitive neuroectodermal tumor change. Maybe some kind of gene look like. I will tell you about it previously in the next lecture. So let us see it one more time. It is a malignant brain tumor. It involves cerebellum, compresses fourth ventricle, which would result in non-communicating hydrocephalus, which have symptoms headache, papilledema. It can involve cerebellar vermis, which would cause truncal ataxia. It can send drop metastasis to spinal cord. As it is malignant, it can send metastasis. Form of primitive neuroectodermal tumor. Homer right rosette, small blue cell surrounding central areas of neuropil. Small blue cell surrounding central area of neuropil. So the next thing is ependymoma, most commonly found in fourth ventricle, which contain ependymal cells. So it involves fourth ventricle. Can cause hydrocephalus and have poor prognosis. Ependymal cells in origin, characteristic perivascular pseudo rosettes. Perivascular pseudo rosettes. Rod-shaped blepharoplast. Basal ciliary bodies found near the nucleus. So this is the histology. Let us see in the picture F. See in the picture F. F. Yes. This is some kind of yes, ependymal cell in origin, characteristic perivascular pseudo rosettes, rod-shaped blepharoplast, basal ciliary body. Yes, these are basal ciliary bodies, rod-shaped blepharoplast found near the nucleus. So you can relate this text to this image. The next thing is craniopharyngioma. As the C indicate, childhood supratentorial tumor, most common childhood supratentorial tumor. Calcification is common, as you can see in the MRI or CT scan picture of this. You can see here the calcification. C also relate to this. Calcification may be confused with pituitary adenoma. Both cause bitemporal hemianopia. As both can cause bitemporal hemianopia. Associated with high recurrence rate. Yes. So both caused by temporal hemianopia, derived from remnant of Rathke's pouch, ectoderm. So it also has cholesterol cysts found in the motor oil-like fluid within tumors. So let us see it again. Craniopharyngiomas is the most common childhood supratentorial tumor. Calcification is a common feature, as you can see in this picture. May be confused with the pituitary adenoma, as both caused by temporal hemianopia. This is the main symptom to remember. Bitemporal hemianopia, derived from the remnant of Rathke's pouch, which is also called ectoderm. It has cholesterol crystals. So the next one is pineal gland tumors. So most commonly extragonadal germ cell tumor. It is extragonadal germ cell tumor. It has increased incidence in males present with obstructive hydrocephalus, compression of cerebral aqueduct. As it will compress cerebral aqueduct, it will obstruct the flow of hydrocephalus, which would result in obstructive hydrocephalus. Flow of cerebrospinal fluid, which would result in obstructive hydrocephalus. So this is called Perinaud syndrome, compression of dorsal midbrain. The compression of dorsal midbrain is Perinaud syndrome. It has triad. One thing is upward gaze palsy, convergence retraction nystagmus, and light near dissociation. So these are three triads which are the main feature of Perinaud syndrome: upward gaze palsy, convergence retraction nystagmus, and light near dissociation. So it is similar to testicular seminomas, spinal gland tumor. Testicular seminoma, as it is also present only in males, so we can relate both of these tumors, and these are derived from extragonadal germ cell tumors, which would compress the cerebral aqueduct and would cause obstructive hydrocephalus. Perinaud syndrome, which is the compression of dorsal midbrain, which would result in the upward gaze palsy, convergence retraction nystagmus, and light near dissociation. So the next one, it is herniation syndrome. So number one is cingulate herniation under falx cerebri, central downward transtentorial herniation, uncal transtentorial herniation. The cingulate herniation under the falx cerebri can compress anterior cerebral artery. This would result somewhat here, where the portion of brain is moving towards this side, towards this side. So central downward transtentorial herniation. This is here where the portion of brain is moving downward. Caudal displacement of brainstem, rupture of paramedian basilar artery branch, durate hemorrhages, usually fatal. It is usually fatal. Third one is uncal transtentorial herniation. You can see here third, this is the uncal process of temporal brain and it is herniating in this direction. So uncal is the medial temporal lobe. Early herniation would result in ipsilateral blown pupil, unilateral cranial nerve third compression, contralateral hemiparesis. Late herniation would result in coma, Carnohan phenomena, which is misleading contralateral blown pupil, and ipsilateral hemiparesis due to contralateral compression against Carnohan notch. So it is, you can say, very difficult to remember Carnohan phenomena. So it is misleading contralateral blown pupil and ipsilateral hemiparesis due to contralateral compression against Carnohan notch. And in this, we are talking about cranial nerve 3. Yes, actually, to understand this, you can. 15 minutes reading. 15 minutes reading. 15 minutes reading. Sorry. Yes, just to understand it, you can see the pathway of third cranial nerve as it leaves the midbrain, midbrain and travels along the free edge of tentorium. So, as is the transtentorial herniation, the uncal process, which is the part of medial temporal lobe, it will exert pressure in the cranial nerve 3. This compression would result in contralateral hemiparesis. So, if there is late herniation, this would result in coma and Carnohan phenomena, which is misleading contralateral blown pupil and ipsilateral hemiparesis due to contralateral compression against Carnohan notch. So the fourth one is cerebellar tonsillar herniation into the foramen magnum. This main part. It can cause immediate death, coma, and result when these herniation compress the brainstem. Brainstem, which is mainly involved in our respiration and heartbeat. So, motor neuron signs. Weakness. So these are upper motor neuron lesions and these are lower motor neuron lesions. Upper motor neuron lesions are mostly in this tone reflex are increased. So weakness, both have weaknesses. Atrophy, lower motor neuron lesions have atrophy and upper motor neuron lesions do not have. Fasciculations are absent in upper motor neuron lesions, and you can see here it is opposite. Sorry. Reflexes are exaggerated in upper motor neuron lesions, opposite to it. Tone is increased in upper motor neuron lesions. Babinski sign is positive. Spastic paresis is positive. Flaccid paralysis is negative as there is increased tone, so there is no flaccid paralysis. Clasp knife spasticity. Yes, spasticity, rigidity, increased tone, these are all related to each other. So there is increased spasticity. So lower motor neuron lesions, everything lowered. Everything is negative. Mean to say, everything is less. You can say weakness. Yes, weakness is less power, so it has weakness. Atrophy is some kind of a negative thing, so it has a negative thing. Fasciculations are also some kind of a negative thing. It has reflexes. Reflexes, we you can say number a reflex, or you can say grade a reflex by its increase in intensity. So as the lower motor neuron lesions have everything lower, so there is lower intensity of reflex. Tone, yes, decreased tone. Babinski's sign, what would be negative of Babinski's sign, which is negative? So spastic paralysis negative, flaccid paralysis positive, because as I have discussed it previously, flaccid means something which is very loosey, and we have discussed is that there is increased tone, so negative paralysis, but it has positive paralysis. Clasp like spasticity, it is also showing some kind of rigidity, so it is also positive in upper motor neuron lesion. Fasciculations are muscle twitchings. Positive Babinski sign is normal in infant. Yes, this is one thing to remember. So upper motor neuron, everything is up. It is everything is down. So let us go next. These are the spinal cord lesions. Number one, poliomyelitis. Yes, this is the destruction of anterior horns by poliovirus. It has fecal oral transmission, replication in lymphoid tissue of oropharynx and small intestine. It spread to CNS via bloodstream. Acute lower motor neuron signs, asymmetric weakness, and you may also see any patient of poliomyelitis in your surrounding, and you can see there is a weakness of just one leg or one arm. So that's why they need a support to walk. So it is asymmetric weakness, and symptoms of viral meningitis may also occur like fever, headache, neck stiffness. Respiratory muscle involvement lead to respiratory failure, which would result in death. CSF shows increased WBCs, lymphocytic pleocytosis, and slight increase of protein with no change in CSF glucose. So poliovirus can be isolated from stool and throat secretion. This is to remember that you may have a question showing that what diagnosis would be more effective if you want to diagnose poliomyelitis. So this is stool and throat secretions which should be isolated.